Hi, I'm Dr. Sanjeev Sokolingam, psychiatrist and obesity medicine specialist at the University of Toronto and scientific director for Obesity Canada. I'd like to speak to you about the intersectionality of obesity with both sleep and disturbances in sleep, and also obesity and mental health. And I'll start with the sleep being the first area of focus. We know that sleep is integral to us in terms of restorative components as well as our day-to-day functioning. Within obesity and obesity care, sleep is integral to the regulation of hormones, part of our circadian rhythm and responses that can impact both appetite and metabolism. For example, poor sleep can increase neurohormones such as ghrelin, the hunger hormone, and can decrease leptin, the hormone signaling fullness. We also know that lack of sleep or insomnia, for example, can impact energy levels, perpetuate or exacerbate fatigue, and can also make it difficult for our patients to make changes in their nutrition and physical activity, and may be associated with circadian rhythm disorders that impact food intake. Large-scale studies have shown that insomnia is a risk factor for obesity, and we also know that individuals living with obesity can develop sleep disorders such as obstructive sleep apnea, which have additional burden and poor quality of life. Therefore, it is so important for us to think about screening for sleep issues, but also recognizing early signs of sleep difficulty where we can intervene with evidence-based interventions for treating, for example, insomnia or complications of obesity such as obstructive sleep apnea. So knowing this, it is imperative for us to think about what are those treatments, both non-pharmacological and pharmacological, or interventions that we can use to support patients' quality of life through this interplay. As for mental health and obesity, there is definitely some intersectionality for patients. There's a bidirectional relationship, which we know. People who are living with obesity have higher rates of mental illness. For example, patients presenting for surgical interventions for obesity have a 60 to 70% lifetime rate of psychiatric illness, mainly mood disorders, anxiety disorders such as social anxiety, as well as eating disorders, mainly binge eating disorders. In addition, we know that for patients who are living with mental illness, developing obesity results in poor course of their illness, meaning they're more likely to have relapses and less response to treatment, which can complicate their overall health and quality of life. Again, screening for mental health conditions and considering this within the context of obesity is critical. And for someone like me who's a psychiatrist, patients who are living with mental illness who are developing obesity should be treated promptly in order to improve their overall mental health course, but their treatment response and quality of life. In addition to the interplay between mental health and obesity in terms of the rates of these conditions, we know there are some biological and pathophysiological connections between mental health or mental illness and obesity. One is in the notion of stigma and weight bias. We know that patients living with obesity who experience significant stigma and weight bias can develop internalized weight bias, where that has become part of one's identity and how they perceive their day-to-day life. And internalized weight bias has been associated with higher rates of depression and anxiety, and as a result, more chronic types of psychological distress. We also know that both many mental health conditions and obesity is associated with pro-inflammatory states. For example, in mood disorders, whether it's depression or bipolar disorder, we have high pro-inflammatory cytokines, and we see that similar state in obesity, suggesting there may be some shared pathways. We also know that social isolation due to associated social anxiety, poor self-esteem, body image disturbance, or the consequences of weight stigma may further perpetuate and be associated with mental health conditions. And likewise, people who are depressed and isolated may find other ways to cope or manage with distress through food and disordered eating, which can increase the risk of obesity. And then lastly, as a psychiatrist, there are many times I prescribe medications for patients who have more moderate to severe mental health conditions, whether it be depression, anxiety, or more severe mental illness like psychotic illnesses. And many of these medications do have side effects related to weight gain and metabolic disturbance. And so the treatments we offer patients for mental health conditions can increase the risk of developing obesity. And this is ever so important for us to think about in terms of our patients, of the potential risks that we may cause in terms of obesity development. And so we should reassess whether some medications are necessary and whether there are alternative medications that have less metabolic side effects, including weight gain, that could be used to both either prevent or to be part of the treatment plan for comprehensive obesity management. It's for all these reasons we have to think about these shared pathways and what are the interventions we can use to fully address obesity and mental health.